Welcome everyone to our Arkansas CQN ADHD monthly practice call. Our agenda for today is roll call and quick report on PDSAs, review of data, parent materials, coding and billing, clinical questions, and reminders and announcements. A few housekeeping items. Please mute yourself if you're not speaking, and please do not put your phone on hold because we might hear your music. And please ask questions and make comments anytime or use the chat box. These slides will be emailed to you after the webinar, and a recording will be made available on our website. Okay, let's start with roll call. I know I'd mentioned to everyone we would have a PDSA question about what you maybe learned or some next steps on your PDSA. And our first practice is Sparks, and actually I can pull up your PDSA if you'd like to see it. I see Dr. Nadvi is on the line. Did you want to let us know anything about something you've learned from your PDSA or some next steps you might have? Hi, sorry. Dr. Nadvi or Dr. Ibrahim, are you on the line?
Yes, we're just getting our patients sorted out, so they're still coming in, but this is Dr. Nadvi.
Hi. I mentioned we were going to discuss a little bit about maybe something you've learned from your PDSA. Did you want to talk about anything that you learned on there?
Let me just have the rest of the team come in. They're all on their way, and then we can go back to it, if you don't mind.
Okay. No, not at all.
Okay, thanks.
Is Amber from Central Arkansas Peds, are you on the line? Okay. I can move on to Pediatric Partners. I see that Gail, you are here, and let me see if I can pull up your, here you go. Did you want to discuss anything about your PDSA worksheet, maybe something you've learned or some next steps?
I can't tell. Is that our first one or our second one?
I believe this is your first one. Or no, I'm sorry. This is the most recent one you sent to me. This is your second one.
Okay. Yeah, that was the PSA we did about on our new issued medications and our change of medications on how we were going to get our phone nurse notified of any medication changes or new medications.
Mm-hmm.
And we found out that we need to improve on our inter-office communication between doctor and nurse and other staff in the building to get that more efficient. But we are still working on ways to do that, so if anybody has any ideas, we're open to that.
Hey, this is Dennis Quo. That's great stuff. But tell me, what are you thinking as far as your next step based on what you learned here?
Our next step?
Yeah.
The nurse that's doing that is we are going to check our schedule every day. And I don't know, the nurse is not here. What is it
But yeah, so Dennis, this is Chris. So yeah,
hey, Chris.
They were relying on me to, once I started a medicine, to send them a short message to have them in 14 days call back. But one of the pitfalls was, in a busy schedule, I wouldn't always remember to do that. So now we have Alicia, our nurse that's in charge of those phone follow-ups. She's going through and looking at my notes after the fact to see if I started anyone on a new medicine or made any medicine changes. And so she's going to be going through the schedule in addition to me trying to remember to send her those messages each time I change a medicine.
Yeah, that's great. That's team-based care. That's awesome. Great.
Thank you. We have River City. Let me see if I can pull that up. Here you go. Dr. Williams or maybe Roger might be on the line.
Yes, hi, this is Roger. Can you hear me?
Yes,
loud and clear.
Roger.
Okay, thanks. I was using the computer connection instead of phone, so I just want to make sure it worked. Our PDSA was kind of our initial one here, basically to see how well the prescribed letter that came, the templated letter that came out with everything, how well that would work with getting our patients to actually activate our portal. So far to date, we've signed up 19 patients, and only 8 of those have activated. However, we do know that since we started using the letter, the initial ones we just told verbally. So since we started using the letter, we are getting better results. I don't have those numbers, so it is helping. Our next step, though, is to contact those patients who have not activated and kind of find out what their problem is, whether they don't understand the letter or whether they're having some kind of access issues with the internet, and see where to go from there. So that's kind of where we are on this so far.
Great, thank you, Roger.
Good news, thank you.
And let's see, Arkansas Pediatric Clinic. And let's see. There you go. Anne Marie, did you want to talk about your PDSA?
Sure. I guess one of our main issues that we've kind of run across is you know, kind of the same thing that was just mentioned as far as, you know, getting the parents to, you know, activate their account, or I guess log on to it after we've, you know, initiated it online. We have given out the list of instructions and stuff to a few, and just a few that we have so far given it out to, I think that it has helped. There's some that we still are not getting the parents to log on, but hopefully that'll change.
Hey, Dennis Quo, can you tell us how many patients do you think have families you've worked with to try to get them to log on, and what's the number of families that you've managed to get that you see have logged on? Do you have an estimate of those? Just kind of.
I would say probably 10 to 15 for sure that have, you know, logged on and actually, you know, filled out the forms and sent them back to us, and we've gotten an email, you know, notifying us that they've been sent and so forth. I'd probably say about 10 to 15. Okay.
Out of how many do you think didn't do it?
I think we've got, I don't have it pulled up right this second, but I think that we have approximately 25 or so.
Okay, so you're hitting probably a little more than 50%.
Okay.
For who are logging on.
Yeah.
Okay. Okay. Yeah. That's great stuff. I think the main thing I would ask is, I think having some of the numbers would also give us some baseline to see how we do over the next couple of months. So that's probably the only other thing that I would ask to try to get some numbers.
Okay.
Yeah, and if they're not totally exact, I think that's fine. I think we, just knowing that it's sounds like it's somewhere about 60% of parents are doing okay with it.
Right. Right.
Okay. Great. Thank you.
Thank you.
And Dr. Nodby, do you feel like your team is ready, or did you want me to just move on?
No, that's okay. They're still getting together, but we can go over it.
Okay.
We were basically, once we were starting to get them in and trying to get them in to see a therapist for counseling, we just wanted to start collecting a list of local providers that we could use. So we've been starting to get different addresses and all that information, so we have it all in one place so we can get them started into counseling and behavior therapy depending on their insurances and different places that they could go to. So yeah, this is basically what we've started to collect for them.
I see your list here. That's a great list.
That's a great list. And so you've got a list here. That's your measure of success is that you've created a list. Did you have a goal number of providers you would put on there, or did you have a kind of a specific goal in mind to try to find a specific therapy?
Basically specific therapies, and then what insurance which providers would accept, because that is the biggest issue.
Yeah.
So, you know, a lot of times that's where we decide where to send them to based on what insurance they will take. So that's what we've been calling around in our spare times. Our assistants and nurses have been doing that, to call and get all the information. So
great. Fantastic. Peter Jensen. Peter, are you there? Okay. The thing I was going to ask Dr. Jensen being on is being able to give us some ideas about what we want to look for in a therapist when we're looking at behavior therapy. So we can ask him to cover that a little bit later.
Okay, that would be good.
Great. Thank you. Great work, everyone.
Great. Thank you. And we have one last one. CAP, Amber, did you want to tell us a little bit about maybe what you've learned from your PDSA worksheet? I see Amber on here, but I'm not sure. She might have.
Oh,
she might
I'm here.
muted.
Can you hear me now?
Oh, okay, great. I can hear you now. Great.
Okay. Well, just one thing touching on what the previous provider was saying. One of the new things that our clinic is doing is we have a psychologist on board that comes and gives counseling to our patients 3 days a week, and then he's here on some Saturdays. So it's been really helpful to the clinic as a whole, but especially our ADHD patients. They'll kind of help with the diagnosis. So since submitting this PDSA cycle, I have had, I believe, 3 patients that have entered into the portal, and then teachers have entered their rating scales too. And I was able to give that to our psychologist to review for behavior therapy, and then helping make the diagnosis for one of the patients as well. So it's just been a good asset for us.
That's fantastic. We're going to want to hear more and more about how, you know, about how things are working with your in-house behavior therapy. Now, this is someone who is co-located. It's not someone who's employed by your practice, but it's someone who's physically in the building or in the office.
Right. They're based out of Little Rock, and then of course we're in Bryant,
right.
And he comes a few days a week.
And some Saturdays.
And I think he started just coming 1 day a week, but now he's here at least 3 that I'm aware of, and then some Saturdays as well.
Yeah, I think that co-location, whether it's someone that you are employing yourself or whether it's someone that's integrated behavior therapy, but co-location is and looking at that warm at kind of a warm handoff is something that I think more and more folks are talking about. So y'all are trailblazing. So thank you. That's we're going to want to hear more about your experiences there as the project goes on. So thank you for sharing that experience.
Yes, thank you.
Yeah.
Thank you so much, everyone. I'm trying to get us back to our webinar. Let's see. Okay. Thank you. And now we will have a review of data with Ed Wise.
Thanks, Kristen. If you just want to go on to the next slide. This slide is just kind of an overview of how the project is going as a whole, now that we have some data to look at reliably. Of course, measure 1 is the percentage of patients that are being assessed for ADHD for the first time that have all of their assessments back within 30 days. You can see that it's pretty much stable, around 50% of the first 3 months. I think the good thing here is that the denominator is climbing up a little bit, so I think that providers are getting the patients into MeHealth and at least getting the process initiated. And 50% is not a very bad starting point. Just hearing from Dr. Epstein when we reviewed this data on the national team, he expected the starting point to be a little bit lower. So I think things are good in research that he's done in the past. Usually it's a much lower percentage of patients getting the assessments completed within 30 days of initiation. So we're starting off in a good spot. The second measure is percentage of patients that are diagnosed in MeHealth and that have been provided the initial conversation and the ADHD booklet from the AAP. This one, I'm kind of concerned that this data is not reflecting reality, and I think the issue might be a data collection issue or data entry issue with the way that things are being recorded in Me Health. So I just wanted to review that a little bit later, and I'll show you what fields need to be completed in order to make sure you get credit for this measure. Measure 3 is percentage of patients with behavior therapy according to what you've been entering into Me Health, and it looks like around 27% for the project. That's all chapters included. The percentage of patients getting assessments back within 30 days of medication prescription or change is around 60%, which is also a pretty good starting point. Again, you can see the denominator is climbing up a little bit, about a 13% reduction in total symptom score, and that's for patients that have an initial assessment for ADHD in Me Health and then have at least one follow-up in Me Health by a parent. And according to the teacher, the reduction in total symptom score so far is 11%. If you can go to the next slide, we'll look at this data for just the Arkansas chapter, and this is just a snapshot of how the chapter overall is doing. And as you can see, we have some pretty low denominators for January where we do have any denominator at all. So I think we're looking at two things, the increase in the denominator and then the rate itself. So in measure 1 for February, you can see now that there was 21 patients assessed for ADHD in that month, and with 2/3 of those receiving the assessments back within 30 days of that initiation of assessment, which is a pretty good rate. Again, these things are kind of difficult to, these processes are difficult to perfect because of the small sample sizes. So I think 2/3 of the time getting those assessments back within 30 days is a pretty good starting point. Again, measure 2, I think we have a data entry issue that I'll talk more about in a moment. And so far it looks like about 14% of the patients entered in Arkansas have been prescribed behavior therapy. And again, measure 4, this is again just for Arkansas. The percentage of patients that have medication started and are getting assessments back within 30 days from the parent and the teacher was 67% in February, and that includes 15 patients in that measure. And then down on the bottom right-hand corner, that's the number of patients registered in Me Health. This includes assessment patients and treatment patients, so patients that are being assessed for the first time for ADHD in Me Health, and those that have been diagnosed in the past and are just being tracked for treatment in Me Health. So then you can see the number of patients entered by practice. Okay, sorry about that, Kristen, go ahead. So measure 1, as I said, denominator climbed up to 21 in February, and with about 2/3 of those patients getting their assessments back within 30 days from the parent and teacher. And if you go ahead and go to the next slide, Kristen, we can see the breakdown on the practice level. So we can see that Mercy went from a denominator of 2 to a denominator of 7, with holding a pretty good rate of 71%, still getting the assessment within 30 days of initiation. And then in River City had the next largest denominator in February with 5. It looks like one of those 5 patients did have their assessment completed with parent and teacher within 30 days of starting it. And then Pediatric Partners and Sparks both had 4 patients assessed. Sparks got the assessments back for all of theirs, so looks like things are going very well for them, and Pediatric Partners got 3 out of the 4 assessments back. Next slide. Again, this is the one that I'm concerned that there's a data entry issue. As you see, there's only 3 in the denominator here, and it's a 0%, which I don't think is accurate. I think probably some of you have had the initial conversation with a patient that's been diagnosed with ADHD and have provided the booklet. But again, I'll talk more about making sure you're documenting that correctly in Me Health in a moment. Next slide. And you can see this just reinforces the idea that it looks like 2 practices have entered a couple of patients in Me Health. Completing the fields allow them to be counted for this measure. So we'll review that again. Next slide. And here again, the breakdown of patients that are being started on medication. having follow-up assessments completed within 30 days. You saw this on the summary slide, but let's go to the next slide and we can look at the breakdown by practice. Here you see Pediatric Partners had 5 patients in February on the lower left-hand side, and all of them had a follow-up assessment, so that's really good there. Sparks looks like 1 out of 2. Mercy, they had a little bit of a drop in the percentage receiving the assessments back within 30 days. They also had an increase in the number of patients that they documented a medication change or initiation. Okay. So this is what I was talking about for measure number 2. And I also mentioned measure number 3 here because you're using the same drop downs. You're just selecting different values for measure number 3. But for measure number 2, make sure that you indicate that there is a diagnosis for the patient, whether it's just ADHD or if you want to indicate one of the subcategories of ADHD. And you do that with the drop down shown here. Next slide. And when you're going to start treatment for the first time, of course, you click the Start Treatment link on the left-hand side of the patient screen. Next slide. And when you're going to indicate whatever treatments you are going to provide for the patient, you also can use these same drop-downs to document the initial conversation with the family as shown here in this drop-down. Next slide, Kristen. And then to add another drop-down, obviously, you just click the Add button that's right underneath the initial drop-down. Next slide. And make sure that you indicate that the parent received the AAP ADHD booklet also. Now, these are way at the bottom of the drop-down, so make sure you scroll all the way down to get to those values and document those 2 items. Next slide. And if you have a patient that's already started on treatment, or if you run out of drop-downs, because you can only add 3 drop-downs in that Start Treatment page, you can also add as many values as you need using this Add Prescription drop-down here on the left-hand side of the patient screen. Now, as I mentioned, these are also the fields that you use to indicate that behavior therapy has been prescribed for the patient. You might notice there's two values related to behavior therapy in the drop-down. One says parent behavior therapy and one just says behavior therapy. You get credit for the behavior therapy measure no matter which one you select. The reason there are 2 values is if you look closely at the guidelines, ages 4 to 12, it does specify parental behavior therapy, but if you look to the adolescents, that parental term is taken out and it just says behavior therapy. So that's why we had 2 values added to the for behavior therapy in the drop-down. Okay. This is just showing that the values are there also.
Well, thank you very much, Ed, and I don't want to rush anyone. We are running a little bit behind schedule, but I'm wondering if anyone has questions on data for Ed or even me-health questions.
This is Dr. Nadri from Sparks Pediatrics. When the patient comes back for a follow-up visit, how do we document that into me-health because the account is already created? We're not making any changes, but he is coming back for a follow-up for ADHD, and we're discussing it. Is there any way to document that into me-health?
No. I mean, if you are getting a follow-up assessment done before the patient comes back so you can look at the Vanderbilt when you have the conversation with them, that's the extent of the documentation that you need to make sure is in me-health. You might not document everything, every interaction you have with the patient in me-health unless there's a Vanderbilt assessment, which of course will be entered in me-health directly by the parent.
So when a child is coming in for a follow-up, we don't get credit for that encounter in me-health as counting towards the 5 patients that we've seen that month, or?
No, and we're counting things a little different than we did in asthma. I know that you're a part of asthma, Dr. Nadvi, so you might be thinking of encounters in terms, or at least MOC requirements in terms of encounters. For ADHD, it's just the number of patients that you enter. So if you enter them into MeHealth, whether it's a patient being assessed for ADHD the first time, or if it's a patient you're just tracking their treatment in MeHealth, they're going to count towards your encounters, so or your MOC requirements, I should say. So if you enter 25 patients, you've met the data entry requirements for MOC for the first cycle of the project.
So it doesn't necessarily have to be 5 per month then?
Well, initially we were saying 5 per month just because we want you to have like meaningful participation across multiple months, not just enter 25 patients in the beginning. But what we found is that some practices were going ahead and entering all their patients into MeHealth at the beginning of the project. And of course, we want them to get credit for participating. They're just kind of being proactive and taking a population approach. So it doesn't have to be 5 every month, but I will reinforce that entering the 25 patients is only part of the MOC criteria. You still have to meaningfully participate across the months by, you know, meeting with your team and joining these calls and providing PDSA worksheets and things like that.
Okay, thank you so much. I think that makes it much clearer.
No problem.
Thank you, Ed. And does anyone else have a question for him? Okay, then we will move on to Allie Stevens from our national team and Natalie Woodridge, our Arkansas parent advisor, who will discuss parent tip sheets.
Hi, everybody. This is Allie. Can you hear me?
Yes.
Okay, great. Is Natalie on the line?
I'm here. I'm just in and out on the mute button. Hi, everybody.
Great. Just wanted to make sure you were here. So I can just provide a quick overview here. So we've been working with the parent advisors in each state for over a month now on developing these materials that we're going to share with you here in a moment. And we kicked it off last month, I believe, with a call that almost all the parent advisors attended, along with our national parent advisor, Elaine Taylor-Klaus, and Jen Powell, our national QI coach. And on that call, we provided another onboarding to the project in addition to your first learning sessions, and gave the parents a number of opportunities to get involved in material development or review. And we got some ideas for these materials and resources based off of what we were hearing from all of you at your learning sessions across the 5 states and 6 chapters in this collaborative. And what we'll come up with is these 2 initial materials that we're sharing with you today. And if Kristen hasn't shared them with you already, then she will. And we're working on other materials that we'll release throughout the project. So I just wanted to give you guys that background, emphasize that these have been extensively vetted by parent advisors across the country, as well as our national team and some of the chapter leaders as well. So we're so grateful to Natalie for being heavily involved in the development of these materials. So rather than me talking about them, which would be very boring for everybody, I thought that we could have Natalie share just some of her perspective on these materials. So the first one is a clinician tip sheet on how to help parents and families process and accept a child's ADHD diagnosis, and that's what you can see on the screen here. That's the first page of it. There's also a second page. But Natalie, my question for you is regarding acceptance of a diagnosis and getting your family on the same page. What's important to know from the parent's perspective?
Sure. Well, like in our family's instance, you know, I'm the one that's usually the one that's carrying the child to the doctor and doing a lot of the follow through as far as what the regimen will be, if there's therapy, medicines, whatever that is. And then I share it with the rest of our family. So that being said, as the primary caregiver, my husband may have a completely different perspective of what's going on with our child that has ADHD. And so, you know, we're actually working on completing the Vanderbilt on another one of our children, our youngest child right now. As we had entered into this study, that was one of the things I had spoken to the group about. But we both looked at a copy of the Vanderbilt. I'm the one that's filling it out because we were given one. But some of the questions he marked completely opposite of what I had marked. And so that's, that's interesting how two parents in the same household can have a different opinion, just as the teacher and the parent could have differing opinions. So bringing those two together to care for the child, I found that really interesting, kind of in my own family's situation. And then there's the explanation with two other siblings, to grandparents and aunts and uncles, and as it carries down, through the family and with close friends on how everyone approaches what their role will be in the care of that child.
Absolutely. Thank you so much. So going off of what Natalie just said, you can see here, this is the second page on the screen of the tip sheet, and parents agreed with what Natalie just said, that sometimes it might be helpful to have them either look at the Vanderbilt together or answer them separately. And Ed will tell you that you can have parents, two separate parents, fill out Vanderbilt and Me Health if you think that's a good way to go. Another tip that some of the parents had was that you might suggest the parent bring their other family members, be it the other parent or grandparent, like Natalie just mentioned, to the next visit to help ensure that they are on the same page. So, Natalie, what challenges have you seen as common around accepting a diagnosis? What are some of the challenges that you guys have had to work with in your family and you've seen with other families?
One thing I guess would be is the depth within the diagnosis. Trying to explain that what is typical child behavior, what's typical child behavior for your child with a diagnosis, and how to discipline and train that child with the information that you have. Because it's almost like when everyone goes through the phase with the newborn, and oh, you shouldn't carry your child that way, or you shouldn't have them at that angle, or whatever. A lot of people have a lot of opinions, but the parents try to process everything that they believe is best for that child, and sometimes that's too much information can be just as bad as not enough information.
Absolutely.
So that's kind of the thing. One thing that I always try to tell other families that I work with, the internet can be our friend, but it can also be our enemy. So not every site, even if it has a trusted name on it, may be the best place for you to get information. You start. We have a very good relationship with our pediatrician in the clinic. I try not to do too much exploration, and as far as my family goes, without trusting the source. Like I said, there's so much information, but there's a lot of things that we've learned from other parents as far as modalities go, like the thing about sitting on a therapy ball. My husband's a physical therapist, and we have a lot of equipment in our house from his days of doing home health, and come to find out that's a wonderful thing for our children that have ADHD to sit on when they were younger and doing schoolwork and are needing some energy and couldn't get outside and play. Things like that I learned from other parents where I'm not, there's some things where it may be diet or extra supplements or things like that. Or even medications. Sometimes I get real leery unless it's a trusted source of information. So that's kind of an issue. We have people who like to share things with us all the time, all the time.
Yeah, and those points actually tie really well into the next material that we're sharing with everybody today. Kristen, could you go to the next slide? So a number of the points that you just made, Natalie, relate back to this next material, which is something for the physicians to give to parents to help them focus on small steps they can take to make progress with their child and family regarding the diagnosis. So there's 4 things here at the diagnosis visit. You can talk to the parent about these 4 things to kind of break it into those smaller steps. Like Natalie, you were just saying that sometimes there can be too much information. So this first one potentially could be really big, learn more about ADHD, but we're specifically referring them to the Understanding ADHD booklet here, and if they're feeling particularly overwhelmed, pages 9 and 10, which address treatment as a place to start. Also suggesting that they talk with their family, keep an ongoing list of questions, and seek out parent support. So all of those things are tying back to what you had just said, Natalie. But could you tell a little bit about why a resource like this might be helpful for parents at diagnosis?
Sure. You know, I think the stigma that comes with labels, and I think that's the first thing that parents hear. But I think just, you know, being able to touch a few points on the piece while we're in the office with you, and then taking it home and being able to read things over more in depth, and, you know, having a good resource list, you know, and just reassuring those positive steps in dealing with the diagnosis, and I think they're listed in there. That gives the parent something that they can just chew on a little bit every day, and share with others too. You know, so it's not just something that they found on, you know, Dr. Google, but it's something that's from an accredited source that they can share with other people, and reread themselves. I think about with my own children, and you know, I have some key printed materials that I have you know, I have bookmarked and highlighted, and there's from time to time where I go back to those and have to read over things because there may be little subtle changes, and maybe I just need a little reminding or reassuring from the right source. So you know. With our latest daughter that we're going through the ADHD diagnosis with, our pediatrician handed us the book from the American Academy of Pediatrics on ADHD, and it was you know, it was nice to open that back up and say, you know, this is the right kind of information for me. Where I could just take it back in little bits and pieces and say, I need to read that. I need to share that with Aunt so-and-so. I need to reach out to other parents, you know. And usually, you know, you're building the parent to be a better advocate. It just, I would think, would be beneficial to your practice to have knowledgeable parents out there who are willing to talk with other parents who are just entering into the process. So
absolutely. So it sounds like, and this is something that we heard from all of the parents, was that having manageable next steps for them to help them feel more informed. And Kristen, I know that we're running a little bit behind here. Are we okay on time, or do you want us to start wrapping it up?
I'm sorry, we have about 5 more minutes left, and I wanted Dr. Kuo to be able to touch upon billing for a minute, and but we so appreciate Allie and Natalie this presentation, and if anyone has questions for either Allie or Natalie, please email me right after the webinar, and I will get these questions to them. And not to cut you off, Allie, did you have anything else that you wanted to say?
No, I know that
okay.
Yeah, go ahead. Thank you so much, Natalie, for joining the call and for sharing your thoughts.
Sure.
Yes, thank you, Natalie and Allie. And I will turn it over to Dr. Kuo to discuss the ADHD coding and billing.
Hey, everybody. we're going to go through this fairly quickly because I also want to have some time for Dr. Jensen to talk about his any ADHD questions that are there. I wanted to go through some pretty fairly straightforward basic on coding, and I'm assuming that folks mostly, if not completely, know the material. So I really want to use this as a discussion point, also for how successful you find that you are at using these billing codes to both document your time and also for payment. One of the issues I think that we'll be talking about more and more over time is trying to increase the amount of mental health care management that we do at the primary care office, partly to be able to serve the kids that we take care of, and partly because of the general shortage of mental health providers that we do have. Now, a lot of mental health management is based on assessments with scales and using those validated tools to help with not only your initial diagnosis but also your management. And that will take time between getting your materials together, administering, interpreting, and such. So the 6-time NM, which is fairly straightforward, is that to understand that if you are using 50% of your time in a given visit spending face-to-face in counseling and coordinating care, if you document it, then you can upcode to a level 4 or a level 5 visit. So, for example, if you spend 30 to 40 minutes and spend more than half that time face-to-face in counseling, and you document, I personally spent a total of 30, 40 minutes in this care of the patient with more than 50% of this time was spent in counseling and coordinating care, then you can code up to a level 4 visit instead of a level 3. Next slide, Kristen. Another thing is to be able to use prolonged service codes, which can be used if you spend at least 30 minutes beyond the time listed in the code being reported. So 99215 is 40 minutes or beyond. 99214 is 25 minutes or beyond. But if you spend 75 minutes in counseling and coordinating a care, you would code 99215 plus 99394. My question is for folks is how often that they're using E&M codes based on time coordinating care and using prolonged face-to-face times. Folks have any experiences using the prolonged face-to-face codes? Folks getting paid for it, different plans?
This is Amber with CAPC.
Yes, Amber.
And we use them a lot for our asthma, but I don't think so much with ADHD. But like the previous slide said, if we state how much of the time was spent counseling, reimbursement's excellent for the prolonged codes.
Great. And I would encourage folks, especially with when we're not talking just about Vanderbilt forms. If we get into pediatric symptom checklist and the SCARED questionnaires and other mental health comorbid conditions that we may want to tease into with ADHD, then I think those codes have become more and more helpful to us. Next slide, Kristen, please. Sick and well visits. This is just to remind us that we can use modifier 25 codes. 99394 is the well code for 5 to 12-year-old and 5 to 11-year-old, and if you use 9213 with a modifier 25. The other thing, next slide, Kristen, is to use. The question is that the issue is being able to use a 96217 for using a standardized instrument. And the question the issue I want to raise is that I have found materials saying that Arkansas Medicaid in particular does not cover 96127s. And I'm wondering if anybody has had any experience using 96127s.
Hey, Dennis, this is Laura.
Hey, Laura.
I've had anybody pay me for that code, so I'll be real honest with you. I haven't even tried it in a couple of years.
Yeah, I mean, I'll honestly, I haven't used 96127. I found something from December 2015 under Arkansas Medicaid that says that they do not cover 96127. I was just wondering if anyone had any other experiences with it. Okay. So I want folks to know that that code is out there. Yeah, I know we always do discuss the value of using the codes anyway to be able to document our services. I'm not aware of anything like that being on the docket for Arkansas Medicaid or the other payers, and that's something I think that we should pursue at the chapter level. But I will also mention that I do think that the appetite to try to pay with more and more of the codes are getting less and less because folks are really moving more towards population-based payments. So I just want to keep that in mind. Meanwhile, we can and should use coding based on counseling time as long as we document properly. Okay. Since we're running out of time, we can cover more of this in future discussions. I did want to have the opportunity for, if Dr. Jensen is on the phone, to be able to have folks run any questions that they have for him. Peter, are you there? Okay.
And Ed has created a listserv for clinical questions so that Dr. Jensen and the other ADHD experts will be able to answer those questions over your email as well.
Okay.
And thank you so much to everyone who's holding for our PCMH call. Hopefully some of the ADHD coding and other issues have been helpful for both PCMH and ADHD. And just a couple of reminders, there's not going to be a monthly call for April because of LS2. Please register for LS2 if you've not done so. And our next monthly call will be on May 24th.